it is a pleasure for me to discuss this topic, which I have to say has been the bane of my academic career. And I want to dedicate this talk to anyone who has ever looked at an echo image and think that, hey, I can do better, right? I think we all have this this idea, right? Particularly our echo fellows. Now, as Shiming said, I know many of you. I met many of you at the CSG Echo Weekend. We collaborated on the NHL combined study, and so I know many of you, and you know that I like to make my presentation interactive. So in this Zoom meeting, it may be a bit more difficult. So I will probably fall back when I ask questions. I probably fall back on the people that I know, and I also know some people who are not afraid to express their opinion. So for those people, be prepared. I may call on you. More than that is that I think it is a very pleasant surprise and to receive an invite from a daughter of a friend of mine, old friend of mine. I think Chris Coppola and I went back a long way, right? We kind of overlapped a little bit when we did our fellowship. And so Dr. Coppola and I mean, it's been a long time. So what I want to talk about is that what do we mean by a good echo? And when we come to that, we need to know what we consider to be a good echo, right? And there are certain prerequisites that we all recognize, right? In order to get a good echo, what do you need? You need someone who's good at acquiring the images. So the technical expertise is given. And I think your lab is blessed with so many good, sonographers. You need up-to-date equipment. And for Howard and I, we've been involved in the project of assessing different echo laboratories. You'll be surprised at some of the outdated equipment that we have seen, right? And I think in current days, you really need all the capabilities, right? So you need up-to-date equipment. Well, not only do you need up-to-date equipment, you need to know how to use the up-to-date equipment, right? The systems are really basically a modern, sophisticated computer. You need to actually know the key knobs that you can play with to get the most out of the system, right? And then finally, I think the one who read it need to know how to interpret it appropriately. And so we all agree, before we go any further, this is the minimum prerequisite we need to get a good echo, right? But after saying that, I've been interacting with so many echo fellows, over the years. I often ask the question to our echo fellow, what do you consider to be an echo, a good echo? And many a time that I think my echo fellow could not answer the question. And frequently they say, no, Dr. Chen, you like it this way, but Dr. Boy was like a different way. The other doctor went this way. And there's really no right or wrong. That's what they would say to me. And the other very common line that they use, they say that you know it when you see it. That is the common line that I see. So, wow, what's a good echo? But you say, wow, once you see it, you know it. And my concern is that if you cannot clearly enunciate to me the criteria of a good echo, I don't think you can then produce a good echo when the probe is in your hands. That is my concern all the time. So the goal of this presentation, I wanted it to be interactive. I wanted it to be short, and I wanted to use it to stimulate some discussion and maybe reflection, even for those of us who've been doing it for a long time. What exactly do we mean when we say this is a good echo, right? Is it really subjective or objective? Are there any really objective measure that we can point to? Hey, this is an echo, so that this can be teachable, so that this can be reproducible. And I think before we go there, we need to understand the basic principle of ultrasound. I think there's certain basic principle of ultrasound that guide us, right? And so before we go there, let me now do what I intend to do. Chi Ming, tell me what are your criteria to call when someone show you a image, you say what? Oh, maybe I should go to Veen first. Veen, I know you. Tell me what you consider to be a good echo image.
Veen is asking you.
Veen, you.
Yeah, Veen, you.
In the back.
Come closer.
Yeah.
Call him by name. He wants you instead of me. Come.
How do you see an echo?
What is a
Well,
good echo?
because you probably scan much more than Chi Ming now, right? So tell me what you consider to be good image.
A good image. I guess it's a good question actually. A good image where you can see an image that on axis first, where you can see all the structures that needs to be displayed, including the heart valves, heart muscles, and to be able to make measurements accurately with those pictures, may it be linear or volumetrics. For valves, a good echo is you can assess the valves, let's say regurg, and not just the qualitative but also quantitative. And there's a lot. I guess a good echo where you can put all this system optimization in an image, including not obviously the principle of the higher the frequency that you use to an image, the better. And if it's color, then the lower the frequency is better. In terms of Doppler, we rely on a good alignment of the Doppler jet with the flow to get an accurate velocity and gradient. For color, we have to watch not to overgain or undergain. So a good setting of a color gain, it's also, you have to pay attention that you have not overgain or undergain the color. But keep in mind, GE color, it's not as good as Philips color. So that's knowing the equipment. So a good up-to-date equipment is it's also good, because even if they're all made at the same time, some machines are dying quicker than the others. So keep that in mind. So
I think those are all very good points, Veen. I think that's very good point. Now let me turn to Chi Ming. Chi Ming, you want to add or amplify any of those points?
So I just want to say that that was a very good answer. I think in many ways, the echo has to answer the question. So before you can answer the question, you have to know what the question is. So it's very important to find out from the referring physician, what is the question? And then what you do is we definitely have our protocol that we go through to make sure the protocol is followed. All the image has to be technically adequate, and each of the frame in 2D in Doppler has to be optimized the way that you would normally do. And last but not least, to use your brain to continue to try to answer the question. If the question is, let's say, a embolic stroke, so whether there's a mass in the heart, whether there's interatrial shunts by 2D, and then there will be questions whether you should use bubble study, agitated saline, and also if it's technically inadequate, whether you should use contrast to enhance the endocardial borders. And if the question is EF, whether you can actually trace the ventricle to get an optimal EF, and when you give the contrast, whether it's foreshortened or not. So these are all the prep keys that should go through our brain whenever we scan.
Now, those are all very good points, right? Now, I want to particularly talk to the echo fellows and the sonographers, right? Now, all these are good points, but my concern about all these points that have been raised is that they are not objective enough. right? In other words, we want to make it so that it's really clearly shown to you that here are the things that you would do. Now, all those things are good, right? If you want to do this, you want to do that. But how? The question is how. And I think my emphasis is that we need to know how to say that you do those things. If I cannot tell you how to achieve those objectives, then you'll be saying, boy, gee whiz, I do this, I do that, and you still don't like it. And we haven't had this in our lab, right? And my lesson my message to the sonographer and to the fellows always that you have to be very specific. You say, this is what you do, this is what you do, this is how you do it. If you cannot exactly say how you achieve that, how are you going to improve, right? So that's the question, right? All the points that Vin and Chi Ming has made are very, very important. But I want to objectify it a little bit more. So that next time when you look at a picture, right? We often, and I come back to the first slide, we look at a picture and say, I can do better. But how can you do better? In what way can you do better if I have the probe in your hand? That's my challenge to you. So reflect on that, right? When you see a picture, you say, I can do better. But exactly in what way can you do better? Because if you want to interact effectively with the echo fellow, you have to be like that. You say, I don't like this, but why do you not like this, right? Is it too dark? Is it too bright? Is it? And they will come back and say, well, boy, gee whiz, this you're talking about aesthetic, right? Aesthetic is something that is personal and subjective. But I'm saying to you is that echo nowadays, we've gone beyond that. There are objective measures that we can do, and I'll put them out, and we'll open up for discussion, right? See whether you agree or disagree with. But I think at this juncture, I want you to reflect on that. Reflect on that point is that how can you improve on the image? When you see an image, you say, what am I looking at? What parameter do I look at to gauge the effectiveness of this echo? And then say to yourself, how can I do better? How can I do better? Now, I'm showing you two echo now, side by side, from two different patients. This peristernal long axis view, right? Particularly to the fellows and the sonographers. I want you to judge which do you consider to be a good echo, right? Now, you look at this, you say, I can tell very quickly what is a good echo. Now, the problem I'm going to come back to you is that whatever your choice is, whether you choose A or B, right? Look at the image carefully. I did not generally, for talk, I would take out everything from the screen so they won't distract you. But I don't in this case, because I want you to see everything on the screen, right? This is from a Philips system. This is what the Philips system will show. Everything is on here. I did not take out anything. The question I want you to think about now is that which you could consider to be a good echo image, A or B. The very, very important question is whatever your choice is, you have to tell me why, exactly why, right? You have to say, I like this because of this, or I don't like this because I have concern about this and this and this. Don't tell me that hey, I like it, but this is good. And if you cannot say to me why you like it, then this is not a teachable moment, right? So look at this now. I want you to reflect on it. I want you to think about it. I want you to be able to say to me is that, hey, which one is good? And I'll come back to it, right? Now, I hope you guys have seen enough of this now. So I'm going to move on, have a good look. And for those that I know, be prepared that I will pick on you, right? So remember, not just A or B, you need to say exactly why. You cannot tell me why, that is not acceptable, right? And you can talk to my fellows, right? I always ask why. I always make sure that they actually provide a reason for their thinking. Because I always say that, the worst thing is to be right for the wrong reason. If you're right for the wrong reason, and I did not correct that, you'll be perpetuated. You have to be right for the right reason. It's better to be wrong for the wrong reason, but it's worse to be right for the wrong reason, right? So I always follow that and ask them. So you talk to any of my ex-fellows, then they will tell you that that's my approach. I always want to be sure that you can basically support your conclusion with valid reasons, right? You don't have to necessarily agree with me, but you have to tell me why. So, what is a good echo? And I would summarize what Veen and Chi-Ming already said, right? What is a good echo is that the aim is to give accurate anatomic and functional data that would help you in answering the clinical question. That is very true. That is the aim. But the question is, how do you get there? Is this a subjective thing? And I would say, no. It's a subjective, is not teachable, right? It is an objective thing. And it's more than when you know, I keep coming back to this line. I always heard that I really object strongly, is that they say, well, a good echo, you know it when you see it. And I would always say, tell me why. If you cannot tell me why, then how can you be objective? I put the probe in your hand, then you cannot reproduce it, right? That's my point. My point is that I hope that I can give you measures that in the probe in your hand, you know what to do. And you need to know precisely what are the objective measures that you can look at to improve on your scanning, to improve on your interpretation, right? Here are the core of what we do. We've been doing this for a long time now, but we have to make it objective. We have to have objective measures so that it can be teachable. Otherwise, how are we going to make things better, right? So the point I think I'm beating to death now, I hope I convince you, right? A pretty picture doesn't necessarily mean a good image. That is my point, right? You look at it and say, boy, that's good. But if you don't apply the objective measure, then that you may be misled. You may be thinking that's good. But I'm saying that probably is just a pretty picture. And that may not be as informative as you like. So the key here is that a good image has to be informative, meaning that it will provide you with all the necessary data that you need. You should extract all the necessary data from one view, right? And when we do show and tell in our lab, many a time we only talk about spend an hour on one view. Why? Because frequently, you can extract almost so much just from one view, right? So it's very, very important. And the corollary to my previous statement is that, therefore, a technically difficult study, a technically difficult echo, does not mean a bad image. That's the key. You can still extract. If you extract all the information out of a technically difficult echo, that is very good, right? So you have to think about it. Is our objective when we do an echo is not just produce a pretty image. We are trying to give a study that provide the maximum information under the circumstances. That's the key, right? All patients are different. I will accept that. And there are patients who are difficult to scan. But the key is that with that patient, you get the most information out of that patient after you finish your echo study. That is the aim. And the idea is that you then provide a comprehensive anatomic and hemodynamic assessment of the patient. That to answer your clinical question that Chi-Ming raised. Very, very important, right? We are trying to provide clinical information, right? To address a question. So don't forget that. Don't forget that. Now, to know what constitutes a good echo image, I think some basic ultrasound principle is important, right? Don't worry, I'm not going into too much physics, right? So no, we'll not go into any detail in physics, but the important thing is to remember what is echo. An echo is using ultrasound. The ultrasound beam is sound wave that penetrates through, okay, and it hit a reflector. Any kind of echo reflector, it bounces back. Two parameters that constitute a picture. What are the parameters? One, the time it takes for the ultrasound to hit the interface and come back. That gives you the location. Two, the interaction between the ultrasound and the reflective surface. That gives you the intensity of the reflective signal, right? Now that's very, very important, right? Knowing that, then you know that the ultrasound image is basically constituted by backscatter of the ultrasound wave, right? Therefore, you get the phenomenon of reflection, refraction, attenuation, and reverberation. These characteristics make up the picture, right? Some of these characteristics are informative. Some of these characteristics creates artifact, right? So those are the basic principles of ultrasound, and I will not talk about physics any more than that. But what does that tell us? Well, they tell us that our 2D is often called B-mode imaging. Now, I hope you all know what the word B stands for, right? The word B stands for brightness, right? So the brightness is a reflection of the interaction between the ultrasound wave and the reflecting surface. Therefore, the brightness tells us a lot about the characteristic of the reflecting surface. How do we quantify the brightness? We quantify using the grayscale. I hope you all know what I mean by the grayscale, right? Grayscale is the degree of grayness on your imaging surface. Your eye can perceive easily over 32 shades of gray, but sometimes it is useful to colorize it. Now, why do you use colorization? Usually some of us like to make, instead of a black and white, to put color on it. Why? Because in certain circumstances, the colorization will improve our appreciation to appreciate the grayscale. And come back to it, grayscale is important. Many of us are not aware of that, and many of our echo fellows really don't appreciate the importance of it, right? And yet this is a very basic, this is very, very important, right? Very, very important. Now it will become more important as I illustrate it. So when we talk about echo images, we always have to be mindful of resolution. Particularly, we are talking about competing technology, right? Frequently, my echo fellow will say, "Oh, well, why don't we do an MRI? Why don't we do CT?" I would say to you that if you haven't maximized the information from an echo, don't talk to me about CT or MRI, right? You have to know that you get the maximum information out of echo before you do it, right? And people often compare resolution of the different study. So we need to know what we are good at and what our strong point is. So the resolution that we talk about there's three important resolutions that you need to be aware of. One, spatial resolution. We didn't talk about that, right? Two, so what is spatial resolution? Spatial resolution refer to the minimal distance of 2 pixels on a screen that you can differentiate, right? Now, in the interest of time, I usually at this point I will pause and ask people, is that what are the factors that affect spatial resolution? But in the interest of time, I see that I'm kind of dragging the talk on too long. So I would say that I'll answer my own question, right? The factors that affect spatial resolution is your transducer frequency, your gain setting, very, very important, right? And things like your TGC. Now think how it affects it, right? And then the other thing that you need to think about is your temporal resolution, right? Temporal resolution is how you determine a the movement, right? The minimum time you take to appreciate the difference in movement. And what determines that? Well, would be your sector size, right? Your sector depth, right? When you zoom it, you notice that your frame rate goes up. So temporal resolution is really easily, you look at your frame rate, right? You want to enhance your temporal resolution, increase your frame rate. Also think about it, right? You really on certain structure that are really, the movement are very quick. What is the maximum frame rate you can get? What do you do then? Do your MO. Why? Because on MO, your frame rate on MO is like 2,000 per second. So for very fast moving structure, there's still a role for MO. Amazing, right? We think MO is gone, right? And then, of course, what has not received enough attention is contrast resolution. Contrast resolution refer to the minimal differences in the intensity or the brightness of two pixels that are side by side. What will affect it? All your settings, right? You overgain it. You want to make the picture bright. You overgain it, the contrast resolution is wiped out. You set your grayscale incorrectly, your contrast resolution wipes out, right? And the other two things that affects it that now are more difficult to adjust is pre and post processing. The pre-processing curves affect your resolution. Now, in our lab, I'm sure your lab is like ours, right? The application people probably come in and help you to do the pre-processing. What does the pre-processing do? They have specific curves or the specific adjustment, right? That they put in ahead of time. And you agree on that. Once you like that, you put in. We now hardly change our pre-processing curve anymore, right? In my early days, that's one of the things that we always look at. In terms of post-processing now, it's also more limited now, right? The post-processing now are down to, we can still adjust is the contrast and the intensity. And you need to know how to do that to maximize the information you get out from the study. So I will come back to say the most important aspect of resolution are those three, right? Spatial, temporal, contrast. And each one need to be optimized. And so it's not what I like and what you like, right? You say, I like too much gain. Fine. Do you know that you're too high gain, you affect your spatial resolution, you affect your contrast resolution. Do you know that? Well, you say, I like to have a great depth so that I don't miss anything. Do you know that by doing so that you impair your temporal resolution? So you have to be very specific in saying, this is what you need to do, and that's why it will makes it a better image, right? So think about that. For the echo fellow now, I think don't forget that. Those are the three aspects of resolution that you always to be mindful of. When you look at a picture, you say, I better make sure that I optimize spatial, temporal, and contrast resolution, right? And don't forget, when you go from the parasternal window to the apical window, you have to readjust it to optimize those aspects of resolution, right? Very, very important. So what is a good image? I'm now putting out some of the criteria that I use for you, right? Number one, you want to be able to see the largest amount of tissue signal variation over the entire sector. Now, why is that? Because the variation in tissue signal variation is what gives you the idea what the texture is, what the tissue characterization is, right? We always talk about, tissue characterization, get MRI. I'm telling you, if you look at the echo image carefully, comprehensively, you will gain a lot of information on tissue characterization, right? So you need, therefore, how you do your setting become critical. If everything is black and white, you lose all the information on texture. So don't talk to me about getting an MRI for tissue characterization. If you show me an echo image that's just black and white, Not acceptable. Not acceptable, right? The other key component that is very important to say is that when you look at images, that light structure should look alike. What do I mean by that? Simple. The septum, if in a normal ventricle, the myocardium and it's everywhere. In the septum, lateral wall, posterior wall should look the same. Why is that important? Because if you set it properly, if they don't look like the same, there's something going on, right? So very key point. It's very straight, very kind of intuitive, but except people don't enunciate clearly. So you set the image so that light structure should look alike. Now the corollary is also important, right? Unlike structure should look unlike, right? What do I mean by that? Well, valves, right? You say now you cannot differentiate valvular tissue from myocardium. Then you are, again, taking out a lot of information from the echo, right? If the pec muscle looks too bright, it tells us something. If the pec muscle look too echolucent, it tells us something. So your setting becomes the key. If your setting is incorrect, all these deductions are gone, right? So come back. You want a good picture. You have to have the largest amount of tissue signal variation. You want to be sure that the light structure look alike. You want to be sure that unlike structure look different. If you cannot do that, then you can never get a good image. So for echo fellow now, the probe in your hands, when you image someone, bear in mind, you look at it, you say, right? These are the basic things that we don't talk about. You don't enunciate clearly, you cannot reproduce it, right? Very, very important. So I'm telling you again that there are objective measures that you can do, right? Of course, you also want to be sure that you avoid artifacts. Now, the artifact, remember, right? The artifact is generated based on the ultrasound principle that I talked about at the beginning, very briefly. But if you understand the basic principle of ultrasound, how the echo image is generated, you will be able to avoid many of these artifacts, right? And Vin already talked about, you want the highest resolution. Well, what do you mean? Well, you want to be able to tell, for example, for spatial resolution, 2 pixels that are side by side. You want to be able to differentiate the 2 pixels instead of 1. And that rely on your proper optimal setting, right? And then tissue characterization. This is a bane on my existence as well, because I think I have this debate with my echo fellow all the time, right? They say, oh, MRI. Well, don't talk to me about MRI. If you cannot extract all the information about the tissue characterization on an echo image, why are you going to something else, right? So what can you tell? Well, you can look at the pixel characteristics within that structure, right? What does it look like? What is shape? What is the intensity variation within it? You'll be surprised if you look at it carefully. It tells you a lot about the property of the structure, right? So yes, can we do tissue characterization? Yes, of course we can. Of course we can. You all seen, right? And myxoma looks very, very different from a clot. Why? If I pause now, I say, ask you why. You should be able to tell me why. If you can't tell me why, then you have not been looking at these structures objectively, right? Very important, right? So when we encounter an abnormal mass, well, what should we do? We make sure that we really describe it in detail, right? You describe something in detail, the diagnosis will fall out, right? So you want not only to I think our alcohols always say size, right? But not more than that. You want to tell me the shape, the position, the texture, and the movement. Texture. How often do we ask the question about texture? I think we should ask more and more. The more we ask about texture, the more I think the operator will be more careful in the setting, how we give us the optimal image, right? The optimal image should give us the greatest variation, grayscale variation. that is the core of what we mean by texture. So let me come back and talk about all the factors. When you're probing your hands, you think about those things, right? I already said pre-processing is basically relatively set. Now, no, in some lab they may have different pre-processing kind of curves set in. So if you're one of those labs, make sure that you pick the correct pre-processing for the patient, right? But in most labs like ours, is that we basically pick one and we generally don't change it. So for pre-processing, you probably will not do much about it. Post-processing, think about what you can maximize it. And the two aspects I talk about, intensity and contrast, can be done. Very important, right? But when the probe in your hands, you think about the transducer frequency, right? We normally talk about, very important, right? The higher frequency, the better the spatial resolution, right? Your gain setting had to be optimal. Your gain is too high, you wipe out a lot of information. Your gains is too low, you may not be able to detect the weak reflectors, which can be very important too. So your gain setting had to be optimal. Remember the issue of TGC and LGC, right? The TGC and LGC helped you to set the image so that light structure look alike and unlight structure look different. Know what the TGC does, right? The TGC and LGC compensate for attenuation aspect of the ultrasound propagation, right? Again, come back to the basic principle that we talk about, right? Remember that your image is generated by backscatter ultrasound signal, which has those properties that we talk about: reflection, refraction, attenuation, and reverberation. These are the basic principles. We always come back to it. And the LGC and LGC help you compensate for that, right? The focal zone, again, will allow you to increase the spatial resolution at certain particular area, know how to use it, right? And optimize your grayscale. The grayscale is very key for tissue colorization, right? You want to maximize it. Yeah, and for most screen now, on our screen, you have 32 shades of gray. If you set it in such a way that you only see 8 shades of gray, then you're missing out a lot, my friend, right? Very important. And yet, I mean, my fellows anyway, they seldom, at the beginning of a rotation with us, they seldom pay attention to it, right? And that you're missing out a lot of information if you don't do that. So now, I'll ask the question now, right? This is A. And I'm sure many of you picked this picture to say that this is the picture, the good picture, right? Now, good or bad, I want to, again, in the interest of time, I'm not going to pick on you now, right? I wish I was physically present with you. I would look at you in your face and say, why is it good? Why is it bad? I'll say to you that this is not a good image. And I'll tell you why, right? If I cannot tell you why should you believe? Look at your septum and posterior wall. The posterior wall is too bright, and yet it moves normally. So therefore, it doesn't fulfill my criteria that light structure should look alike. 2, look at the left side of the screen. Look at the ventricular septum. As the septum goes more apically, it gets more loosened. Why you shouldn't be like that? You should set it in such a way that light structure look alike. Again, it doesn't do that, so it's not correct. Now you say, whoa, normal study, why is it important? Incorrect. I'll tell you, if you set the image properly, if the basal posterior wall is echo dense compared to other area, it raises the question of another diagnosis, right? So it's not a minor point, right? And then the other thing, you look at the grayscale. The grayscale is the the bar on the right-hand side, do you guys all see the bar under M1? That's your grayscale, right? I submit to you that the grayscale is not adjusted properly. You should be able to see multiple 32 shades of gray. Do you see that? No, you don't. So the grayscale is set inappropriately. So this is not a good echo image, right? Because the setting is improper, it's misleading. And lastly, and I think Vin pointed this out before, obviously penetration is not a problem, right? Why is this a G? It should be in the highest resolution. You want to optimize your spatial resolution, so you go to R, right? So these are really basic things that you can point out. It's objective. I'm telling you, I look. So for my echo fellow who come back with the image, I say, look, you can do better. This is how you can do better. Improve your grayscale. Your TGC is not set properly because light structure don't look alike, right? Your LGCC is not set properly. Again, look at the septum. Light structure is not alike. Also, you should have much better resolution if you go to R instead of staying at G. And many of my fellow would probably stay at G in a patient like this throughout the entire study, which is inappropriate, right? So I'm saying to you that it looked like seemingly a pretty picture, but it's not a good echo. You're missing out a lot of information. This can be a very misleading echo, right? If this patient is sent in for a specific diagnosis, I may not be able to make the diagnosis, right? Very, very important. So this is not a good echo. So let me then come back to try to summarize for you what I consider to be a good echo image, right? Obviously, you need to have appreciation of the basic principle of ultrasound so that you would minimize artifacts on your image. You will achieve the highest resolution. Remember, when we talk about resolution, it's not just one thing, three things, right? Spatial, temporal, contrast. You want to provide the information on tissue characterization. In order to do that, you need to optimize your three resolutions, right? Very, very important. And remember all the settings that in your hands that will affect those, right? We already talked about that, so very, very important. And these are the factors that we'll show it to you again. Think about transducer frequency. If penetration is not an issue, go to the highest frequency because that gives you best spatial resolution. Remember that the spatial and contrast resolution is affected by your gain setting, your TGC, your LGC, and your focal zone. Remember the importance of maximizing the grayscale. You have trouble with the grayscale, you can colorize it, but remember what the colorization does, right? It actually tries to optimize your visual appreciation of the grayscale. That's what does it. It's no more than that. It's not making the picture more beautiful. It's trying to make sure you appreciate the tissue variation, right? And finally, this is my last slide. The element of image quality are objective, not subjective. It's not an issue of aesthetic, right? And I hear that it's not something that, yes, you see it, you know it when you see it, but you have to be objective to come out and say why you know it. And here are the parameters I always go fall back on. 1, light structure should look alike. 2, unlike structure should look unlike, right? Simply stated. You say it in such a way that you cannot tell that's not a good picture. You want to make sure that you're the fluid dynamic range, meaning that you optimize your grayscale. You make sure that the boundary between different tissues are clearly visible. And finally, you want to make sure you depict motion accurate that come back to your spatial resolution. So these are the elements you can use to assess each picture. So I'll come back to you. Yes, you know it when you see it, but you better have your objective measures in mind. Otherwise, you cannot reproduce it when the probe is in your hands. Okay, I'm ready for a question now. I think I think I ran longer than I expected. I was hoping to have more time for discussion.
Thanks, Kwan. Kwan, it's Bob Howard. Chi Ming and Howard Leopold both had to leave for other meetings. So you're stuck with an old guy who's probably predates you a little bit.
No, you don't predate me. When did you start?
Right?
When did you start?
When did I start? My fellowship in ECHO in 1980.
1980?
Yeah.
Well, I start. Yeah, then you start about the same time as me. You start with EMBO, right?
2D, it just came in. The variant had arrived.
Yeah, then we are about this. We are about to start about the same time. I start when we were to predominate EMBO, and the 2D. You're right. 2D just came in. So now you're not that much more senior than me. All right, go ahead. Any questions from the? I think particularly I like to hear questions from the sonographer and the echo fellows, because I think the bane of my academic life is try to tell them that, hey, is objective, is not what I like and what you like. Because I hear that all the time. They come, they say, yeah, no, Dr. So-and-so like this, like setting this way, Dr. So-and-so like this. I said, no, this is not what we like and what don't like. If I cannot tell you what I like, then it's not teachable, right? And I believe it's teachable.
So Kwan, we're going to open it up. I have one quick question, and it's something that occurred a few years ago, which is harmonic imaging, which
Right.
gave a lot of benefits in terms of the difficult to image patient, getting images where in the past we didn't get anything. My sense is we now tend to use it all the time, as opposed to some of the time. What do you do in your lab with that?
I think that's a very good question too. When it first comes in, I have a lot of reservation about that too. I'll tell you what it's good at and what's not so good at. Look at the element of image quality, right? What the harmonic does is that it definitely much superior in taking away artifacts. So the boundaries, particularly endocardial margins, are much more clearly visible. What it's not as good is that the dynamic range, to my eyes, a little bit different. If you try it, right? In someone with good images, do fundamental imaging and harmonic imaging. In fundamental imaging, the tissue characterization is a little bit better, I believe, but the boundary are not clearly seen. But I think, taken over in our lab, the same thing, right? Because I think unless you have people with very good images, people generally like to see very clear, visible boundaries, right? From blood pool to the myocardium. So I'm afraid that harmonic imaging has won out. I think in people with very good images, I sometimes will ask them to do fundamental imaging, particularly when you're talking about cardiac mass, because I think the dynamic range is a little bit better. And so I still do that from time to time. But I agree with you. I think in most labs now it's all harmonic imaging because there's a less artifact and the boundaries are more clearly visible.
Thank you. So questions?
Yeah, I think someone raised a hand. Go ahead.
Thank you, Dr. Chan, for an outstanding review. You focused mostly on 2D imaging. You didn't get into Doppler and other aspects of echo due to time constraints. You were trained at the Mayo Clinic, which is unique in the sense that the sonographer and the physicians work as a team, but the patient, after they've had their echo done by the sonographer, the patient, while they're still there, the physician reviews the study, and they, as a team, make the decision whether the study is adequate or not before the patient is actually let go. In what proportion of the Canadian labs do you think that's happening? Because echo is a team sport. So a sonographer and a physician work as a team. But if I'm playing center and the sonographer is playing a midfielder, I can't replicate the midfielder's play. So if a sonographer cannot get a right parasternal non-imaging Doppler of an aortic stenosis jet, it's unlikely I'm going to be able to do that as a physician. I'd like you to comment on that.
Now, interesting, right? That's an important point. I'll tell you what we do in our lab. I think in our lab, there's always an echocardiographer assigned to the lab. So, for example, I'm assigned to the lab this morning. I'm available all the time, and the sonographer knows that if there's any issues, technical or otherwise, they can come and talk to me about it, right? And I agree. Any echo laboratory, in order to improve the quality of the study, it requires an active interaction between the reader and the sonographer. An important thing, like I said already, if you say to the sonographer, you say the pictures can be better, doesn't carry much weight. You should be able to say the image can be improved if you change the near gain, if you change the TGC, you change the image frequency. So you have to be very specific. The more specific your constructive criticism, the more likely you're going to improve on the scanning, right? So that's very, very important. And then I think for you're right. I mean, the technical ability of us now reading echo, I think that become a question if you don't scan a lot. I have the benefit that I know I scan. I think my scanning ability is quite good. So if they have trouble getting certain views, certain structure, they will come to me, and I'll show it to you. Particularly for congenital cases, right? How you approach them, they will come to me for complex cases, and I'll go in. I will scan and show them how I approach it. I think that will be the only way to improve it, right? If you read, and Howard and I review other labs, in labs where you review afterwards, there's tough to do, right? A feedback is most effective is immediate. If you tell someone that this is not right, a week later, it's not effective. So for echo fellows, particularly, if there's something that I find, I will talk to them right away. I want to make sure that they know how I feel. But again, be as objective as you can with the suggestion. Otherwise, they cannot improve. So don't say it's bad image, but say these are the areas that you can do differently, and show them that you do those things differently. The picture become more informative. I think that's the way to do it. I think we all need to go back to work, right? So thank you for inviting me, and I hope it's helpful to some of you.
Kwan, on behalf of all of us, great to see you. And you, as Chiming said, you are a bit of a legend, not just in Ottawa, but all across Canada. So great to hear your talk today, and wish you all the best.
Thank you for inviting me.
Take care.